Let's begin our session with Umar Kitab Al-Fatihah. Okay, before I begin, there's a possibility we need to have hopefully a short break in between the session, just because they're gonna have a procedure in our NICU, I think around 9:30, 9:15 like that. But we're not sure. I hope they're going to come a bit later. But anyway, let's continue first, and then we'll see how everything goes, inshallah. Okay. All right. So today I'm going to talk about, what's the topic today?
Prematurity and its complication.
Yeah, prematurity and its complication. Okay, let me share this slide. Okay, all right. Can you see my slide?
Yes, doctor.
Okay. All right. So prematurity and its complication. So the first thing is being a premature baby. So you know, premature, they are immature from head to toe. So everything about the baby is still immature, is still not ready yet. The system, the physiology is not ready yet. Many parts is not even formed yet. So there's a lot of problems with prematurity. And first, we need to understand some of the definitions, which babies that we define as premature babies. So preterm babies, premature babies are infants that are born before 37 weeks gestation. So until 36 plus 6, they are still considered as premature babies. 37 weeks, 37 plus 0 and above gestation age, they are considered as term babies. So then the recently is many years already lah. So late preterm infant are infant born between 34 and 36 weeks gestation. Moderate preterm are 32 and 36 weeks, and then very preterm babies are less than 32 weeks gestation. Why we define as this is because this is actually associated with issues with the physiological development actually. And then low birth weight babies are those infants who weighs less than 2.5 kilos. VLBWs are those less than 1.5 kilos at birth. And ELBW are those born with weighing less than 1 kilos at birth. So they most of them are premature, but some of them may also be term babies who are IUGR and so on and so forth. Okay, so again, less than ELBWs account for almost 1% of live birth in the US, and VLBWs account for 7% of live birth in the US, and so on and so forth. So there's a lot of premature babies, IUGR babies, low birth weight babies. They are associated with several birth defects as well. So babies with birth defects, a good percentage of them actually born with they are also have low birth weight, and some of them are premature as well. So okay, I think we are not going to go for that. So what I'm trying to show is that is an issue as well in the United States. So prematurity and also low birth weight babies are also a problem, not just in Malaysia, but also in the United States, and also a problem around the world. And they are associated with birth defects, they are associated with SIDS, they are associated with RDS as well. These are all the causes of infant mortality. And birth defects actually account for the highest, and prematurity is the second. Okay, we are going to go through that. Again, is associated, so prematurity associated with extreme ages, ages of maternal age less than 18, and also maternal age more than 40. And then maternal race, I'm not going to go for that. And having a premature baby is associated with huge economic consequences. For example, we have a baby now in our unit in NICU in our hospital. So this baby was born a bit premature, not even very. It's around 32 weeks gestation. But with this baby, this same baby that we have here also have problem with birth defects. Had arthrogryposis multiplex, congenital arthrogryposis multiplex. So this baby was ventilated, so already stayed in our hospital for 87 days. So 3 months, almost 3 months already stayed in our hospital. And the total charges, the total bill for this baby is already 30,000 ringgit for just one baby. We've had one baby who we discharged, I think I think around 1 month ago, was admitted for exactly a total of 60 days in our hospital, was never ventilated, had PDA in failure. This baby, for that 60 days of admission, the charges for that particular baby was 23,000 ringgit for just one baby. Any one of you think you can pay 23,000 ringgit for admission? And this baby will need to be referred to IJN. We need surgery done in IJN. And that will cost more. We've had one baby, I think 2 months back. Parents were apa nama ni? Asylum seeker. Parents were asylum seeker, Rohingyan asylum seeker under UNHCR. Baby was born with hypoxic ischemic encephalopathy, was intubated, was completed cooling, intubated briefly, only I think less than 24 hours was intubated, was given cooling. This baby stayed with us for I think 13 days, less than 2 weeks. The total bill for this baby was 18,000 ringgit for a 13-day admission in the hospital. So can you imagine? It costs a lot, and these are just for specific babies. How about the cost for the hospital? How about the cost for this? Is just for this admission. Do you think just this admission is enough? No. The patient needs physiotherapy. The patient needs further follow-up. So these are all associated with huge costs. If you go to United Kingdom, for example, UK. So UK has a universal healthcare system, the NHS. So the NHS in UK. So NHS, how they work in UK. Each hospital, though, is not owned by the government. There's no such thing as government hospital in UK. So each hospital is owned by a trust, yayasan. Dia ada yayasan, the trust own the hospital. So this trust, they may be paid by NHS or they may be paid by private. So if they're paid by private, maknanya patient lah yang bayar insurance ataupun out of pocket duit sendiri. Ataupun they may be paid by NHS. So all people in UK, they are covered by NHS. So hospital, they akan charge to the NHS per patient. For example, a baby who's admitted in NICU, the hospital will charge the NHS for 1,000 to 1,500 pounds per day. So babies who are admitted in HDW, the neonatal HDW, the charge is around 500 to 800 pounds per day. So babies who are admitted in SCN, for example, the charge is on 300 to 500 pounds per day. Babies who in transitional care, the charge will be 200 to 300 pounds per day. So all these are the charge to the hospital. Can you imagine 1,500 pounds per day? If in Malaysia, the charge will be around 7,000 per day. That is per day. Can you imagine what's the cost? So it's a huge cost. It's a huge burden. And I'm not talking about the charges after discharge. This is just during admission. And for procedures, everything is charged. And you know, especially if patients was admitted in our government hospitals in Malaysia, Do you think it's free? No, it's not going to be free. Because why? Yes, for admission, the stay in the unit is almost free in Malaysia. It's very minimal. The charge, if you are admitted in government hospital, the charge is minimum for the stay. But you will be charged for the investigation. CT scan, for example, in government hospital will be charged 300 ringgit. MRI will be charged, I think around 400, 600 ringgit for MRI. ECG, each time you do ECG, the charge is 15 to 30 ringgit per ECG. FBC, everything will be charged. And sometimes premature babies, I've had premature babies who are admitted in our neonatal intensive care unit for 1 year plus. The baby stayed with us for 1 year plus. Can you imagine? A baby staying with us in the hospital for 1 year plus. Can you imagine how much the government is going to pay for that? An average length of stay in the hospital with prematurity, average length of stay is 24 days. Average is 24 days. Some may be longer, some may be a bit shorter. But mainly the length of stay is very long. Average around 24 days. And all this will be charged to someone. And this is in the United States where the healthcare you need to pay and everything. Not everyone has insurance, and the current outgoing government is trying to repeal the Affordable Healthcare Act. So okay, I think we need to, and the cost for the employers, the cost for the hospital, the cost for everything is monumental. Long-term care costs. So healthcare costs, you need to pay for the community health services. You need to pay for the physiotherapy, occupational therapy, speech and language therapy, social services, out-of-pocket expenses, traveling, and so on and so forth. I remember when I was in HUSM, in Kelantan, we've had patients who live in Kemaman, for example, live in Dungun, so they live very far. They live in Besut, so they need to travel. So, and each time they travel, it costs a lot of money. Currently, we've had patients, babies admitted in our NICU, but parents live in Kemaman. Kemaman, although is 1 hour travel, but still it's 1 hour travel. And it costs money at this age of pandemic where people don't have much work. People if they don't go to work, they won't have money. So who's going to pay? It's a huge cost for them. I told you about my patient whose parents are Rohingyan, isn't it? They don't have a car. They only have a motorcycle. So father comes to the hospital on the motorcycle. Father brings the mother to the hospital on motorcycle. Few days, less than a week after birth, mother wants to see, kalau mak nak jumpa baby, mak kena naik motorcycle datang tengok baby dia. Can you imagine? Less than a week after delivery, naik motorcycle nak jumpa baby. If not, dia kena naik Grab, and that costs money as well. You think it's cheap? It's not cheap going by Grab. And when I discharge the baby, they had to go by Grab, datang hospital, settle semua, settle bill, panggil Grab datang ambil. Sebab bawa baby tak boleh naik motor, kan? Dia naik Grab. Can you imagine? All this cost money. And the father is a refugee, is just an odd job worker. So 1 hour of not working, it will cost money to the family. So the father need to work several days just to pay for the cost of coming to the hospital. Sometimes kita take it for granted je, kan? Kita semua student UIA, ada PTPTN, ada scholarship, ada apa semua benda, kan? We take it for granted that we have so many things going for us, but there are so many people that are much more problematic, has much more problem other than us. Okay, we're not going to go about that. Preterm birth and prematurity is a common but complex disorder. There's some genetic contribution. So those who has family who's born premature, they are more genetic. They have genetic preponderance. They may have more family members who are born with prematurity as well. There may be environmental influences, and also there's some gene and environment interactions as well. So that is why family history of prematurity is actually important for you to assess whether this baby may be born premature as well or not. So prematurity is the #1 cause of neonatal mortality in the United States, and is the second cause of infant mortality in the United States. So again, as I said before, babies who are born premature, the problem is from head to toe. At the neonatal period, many of them are born with respiratory distress syndrome, RDS. They need ventilation. RDS or hyaline membrane disease. So they may be born, they may need intubation, ventilation. Intubation and ventilation is not cheap. Intubation and ventilation, it costs around 300 to 800 ringgit per day. So the cost is a lot. They may have bleeding in the brain with intraventricular hemorrhage. They may have periventricular leukomalacia, which is associated with more neurological sequelae later on. Prematurity is the highest, is the major risk factor for NEC, necrotizing enterocolitis, which is among the most severe complication in any baby, where the bowel get inflamed, it may become ischemic, gangrenous, and so on and so forth. I've had babies dying with necrotizing enterocolitis. I've had babies who need multiple surgeries because of necrotizing enterocolitis. They may have patent ductus arteriosus. They may have, they are more prone for infection. Why? Because their immune system is still immature. So they may not initiate adequate immune response to actually fight any infection. So that is why they are more prone for infection, and they are emitted. They have lines in multiple venipunctures. All these are risk of infection. They may have long lines. They may have femoral lines. All these are risk for infection. They are not exposed to the external environment. You know, when we are exposed, if you ever heard of the hygiene theory says that we are stronger, our immune system are stronger because we are exposed to certain bacteria, good bacteria, and so on and so forth. So our immune system develop. But when babies are admitted in NICU, they are not exposed to the community community microbes. So their immune system are not developed well, and they are more exposed to the NICU bugs, which are more resistant and more dangerous. They may have lots of metabolic abnormalities and nutritional deficiencies. They are on TPN. They may develop rickets of prematurity. They may have anemia of prematurity. There's a lot of problem. Short-term effects, they may have problem with feeding and growth difficulties. Why? Because many of them are ill. So when they are ill, they are kept meal by mouth, or even if they are fed using tubes. So when they are fed using tubes, they are sucking development, they are not developed. So we need to train them. Many of them, we need to train them to actually feed and suck. You know, sucking stimulation is only developed around 34 weeks gestation. Before 34 weeks, these babies, they cannot suck. So sucking reflex actually develops around 34 weeks. Before 34 weeks, these babies, they cannot suck. So that is why before 34 weeks, they macam mana pun dia still nak kena tube feeding dengan rice tube, sama ada orogastric tube ataupun nasogastric tube ataupun jejunal tubing. So bila kita semua suck feeding using tube feeding, the sucking and everything is not developed. Sometimes we need to train them. And many of them also have feeding issues. They have swallowing incoordination. They may have issues with feeding intolerance. And so there's a lot of issues. They may have apnea of prematurity. You know, breathing is controlled by the cardiorespiratory center. Where is the cardiorespiratory center? It's at the mana? Kat mana? Cardiorespiratory center.
Brain.
Memanglah brain.
Brainstem.
Pons, it's at the pons. So cardiorespiratory center is at your pons. Nasib tak cakap body kan? So cardiorespiratory center is at your pons. So this is where your breathing and your heart rate is controlled at your pons. The cardiorespiratory center got stimulation from your carotid body and aortic body kan? So cardiorespiratory center. So in these premature babies, the cardiorespiratory center is not mature enough. So they may have apnea of prematurity. Apnea of prematurity ni just the baby forgets to breathe. Dia lupa dia kena breathe. Why? Because the cardiac center is not mature enough. So this sort of babies ni yang kita bagi caffeine. One of the treatment for apnea of prematurity is caffeine. Caffeine. Dulu-dulu kita biasa bagi aminophylline, theophylline. But now we know that theophylline, aminophylline has more risk with tachycardia and so on and so forth. So caffeine is among the safest drug to give to any baby. And then they may have neurodevelopmental difficulties. They are associated with cerebral palsy as long term. They are associated with retinopathy of prematurity. So studies have shown. So we used to believe that retinopathy of prematurity is actually caused by oxygenation. So you know oxygen is a drug. In air, the concentration of oxygen is 21%. This is normal air. The air that we breathe is 21% oxygen. So sometimes for newborn resuscitation, we may give higher oxygen concentration. So the postulation is that the more oxygen you give, oxygen itself is a free radical. Oxygen can cause retinopathy of prematurity. Sampai dah? Dia nak start ke apa? Okay, kita lagi rekam. Okay, fine. So oxygen is associated with retinopathy of prematurity, and oxygen as well is associated with bronchopulmonary dysplasia, chronic lung disease, because of high oxygen. But now more studies have shown actually the main cause for retinopathy of prematurity is prematurity itself. So prematurity itself causes retinopathy of prematurity. Okay, they may have transient dystonia. As long term, they are associated with cerebral palsy, sensory issues. They may have special needs. Because in the hospital, they have incomplete catch-up growth, school difficulties, behavioral problem, chronic lung disease because of bronchopulmonary dysplasia. I've mentioned before, another issue with infection is because many of them have delayed immunization. Like our baby here, almost 3 months in the hospital, haven't received any vaccination yet so far. So they are more at risk for infection. Okay, okay, these are all causes for why babies develop prematurity. Spontaneous, it may be clinically indicated because mother or fetus is at risk because of many issues. Okay, I think we need to, because they're going to do procedure on one of my baby here in NICU. I think let's see now. So you have class at 10, is it?
No, Doctor, 11.
11. Okay.
Yes.
Can you give me another 15 minutes? Let's have a break for 15 minutes. So we'll continue at 9:45. Is it okay? Terpaksa lah because.
Okay.
Okay. So come back in at 9:45.
All right, Doctor.
Okay. All right. Okay. Let's stop here. Okay. Let's continue with our presentation. I'm very sorry. There's a baby that we've done. I told you about the baby that's already here for almost 90 days kan. So diorang baru buat scope tadi, tracheostomy and everything. Okay, right. So spontaneous preterm birth, preterm labor. The presentation usually they come from preterm labor for 50 to 60%, and some of them is because of pre-labor premature rupture of membrane as well. And then, okay, let's see. Some are delivered because of maternal indication or fetal indication, such as preeclampsia, fetal distress. We've had one baby yesterday delivered because of impending eclampsia. And then because of IUGR, abnormal Dopplers, or placental abruption as well. Placental abruption is a very complicated problem because the baby may have low blood from because of the abruptio placenta as well. And I've had even one baby who was born with uterine rupture. So uterine rupture is a very complicated punya issue where the uterus actually ruptured, and when when they delivered the baby is already out of the uterus, and obviously the baby was born with severe hypoencephalopathy, was born in a very bad condition. Actually, baby died. So again, I said before, prematurity is associated with extreme maternal ages, less than 18 and more than 35, more than 40, low socioeconomic status, unmarried parents, and also some racial punya issues as well. Known risk factor is history of prematurity. When you have siblings that are born premature, the pregnancy also is a risk of delivering premature as well. History of spontaneous losses and genetic predisposition, and so on and so forth. Tobacco use, alcohol abuse, and so on and so forth. Okay, maternal illness. So there are lots of, because the issue with this is that you need to one of the thing that you need to one of the how you should treat prematurity is actually to preempt. So which mothers are at risk of delivering premature. So because we need to plan premature deliveries, it needs to be a planned deliveries. It needs to be pediatric team need to stand by. It needs to be a planned standby. You cannot just rush. So it needs to be a plan. So multiple gestation is another risk factor. So if you have twin or multiple pregnancies, so these are all risk factor for preterm birth. Okay, let's go there. We're not going to go there. We're going to go a bit faster. So scans, we're not going to go. These are all with mother. Let's see. Let's go a bit faster. Sorry. So fetal causes. So fetal causes there's uterine causes. There's also fetal causes. Fetal causes such as fetal distress, multiple gestation, chromosomal disorders. So babies with chromosomal disorders, they are more at high risk of delivering premature. And then polyhydramnios, trauma, premature rupture of membrane, iatrogeny, and so on and so forth. So what are the problem with prematurity? So they can have acute problem. So among the acute problems of babies born premature are things like hypothermia. So why they have hypothermia? So premature babies, they have less brown fat. So brown fat is very good for thermoregulation. So when you don't have brown fat, they are at risk of hypothermia. They are at risk of hypoglycemia, hypocalcemia, respiratory difficulties with RDS. They are at risk of intraventricular hemorrhage, liver immaturity, liver abnormality. They are increased susceptibility for infection, NEC as mentioned before, PDA, feeding problems, anemia of prematurity, retinopathy of prematurity, metabolic bone disease of prematurity, rickets of prematurity. So these are all problems that may happen to premature babies. Hypothermia, why? First is they have higher surface area to body weight ratio. Do they have higher body surface area? No, they don't have higher body surface area. But what they do have is higher body surface area as compared to body weight ratio. So this is what they have. When they have higher of this ratio, they can lose more heat from the environment, and so on and so forth. They have little subcutaneous fat. They have less decreased brown fat. So brown fat is very good. It's very efficient for thermoregulation. It keeps your body warm. They have inadequate sweating mechanism because the sweat glands are all immature. They have immature heat regulation mechanism. The thermoregulatory center is still immature, so they cannot control their body temperature well. Hypoglycemia. How they develop hypoglycemia? Because they lack glycogen storage in their liver. They have immature hepatic and autonomic responses, though they don't respond very well to hypoglycemic event. So when you are hypoglycemia, your body, your metabolism should respond, your liver should respond. But in premature baby, the hepatic system and the autonomic responses are still immature, so they don't produce the adequate response to actually maintain adequate glycemic control. So this is a problem. And you know, high sugar is dangerous, but low sugar is much more dangerous. Hypocalcemia as well, because why? Early hypocalcemia occurs due to immaturity of the hormonal control system, their parathyroid hormone and everything. They are not mature enough to respond well to and then to have higher calcium levels. So they are more at risk for hypocalcemia. And with that, with hypocalcemia, they may develop into rickets of prematurity. The alkaline phosphatase, if you do tests, what you can see is the alkaline phosphatase will be very, very high. So alkaline phosphatase is usually elevated in children who are growing, because alkaline phosphatase can be found in bone and so on and so forth. So in growing child, the alkaline phosphatase is normally high. But in babies with hypocalcemia, in babies with rickets or prematurity, the alkaline phosphatase will be very, very high. And then respiratory, they are more at risk for hyaline membrane disease due to surfactant deficiency and leading to RDS, so respiratory distress syndrome. So why did it, so RDS, what's going to happen? You can see if you do X-ray, you will see what? You will see reticulonodular changes. Reticulonodular changes. So this baby may born with respiratory distress. How do they present? They present with tachypnea. They present with increased work of breathing. They may present with grunting. What is grunting? Grunting is the sound that we make. Dia nak maintain, dia nak increase dia punya peak and expiratory pressure. Dia bunyi macam so that is grunting. Nasal flaring, subcostal recession, intercostal recession, tracheal tube. So these are all signs of RDS. And usually, what's the treatment? The treatment is usually giving surfactant. So you give surfactant. So surfactant you can give either by lavage, you can give by insufflation. So you give. So there's so many other methods. So sekarang ni ada method kita panggil LISA, for example. LISA is less invasive surfactant administration. So kita bagi, dia ada guna rice tube saja, kan? You bagi rice tube and it's powered by CPAP. So dia ada banyak method. Ada insure method. So insure method ni maknanya baby yang premature baby with RDS at birth, kita intubate, kita bagi surfactant dan kita extubate. So this is insure method, for example. So kita bagi surfactant. Surfactant ni pun ada isu. What are the issue with surfactant? So surfactant ni, it can either be, dia ada beberapa brand lah. Brand yang banyak hospital guna is Sevanta. Ada brand Poractant Alpha, ada jenis Beractant, ada Calfactant. So ada banyak jenis. So apa beza dia? Poractant Alpha, Sevanta, they are porcine based. Dia ambil daripada porcine. So Beractant, Calfactant dia ambil daripada cow, daripada lembu. So halal ke tak halal? Is it halal or haram? Nah, cepat student. Al-Jami'ah Islamiyah Alamiyah. Al-halal wal haram.
If no choice, halal.
If no choice, then halal. Sudah.
Dari porcine tu kira ambil tisu ke ambil apa?
Ambil dia punya surfactant lah. Daripada dia punya lung. Macam mana?
Tak ada istihalah dulu ke?
What is istihalah? Istihalah is you change one substance to another substance. Kan? That is istihalah. So kalau you look at fatwa Qaradawi, apa nama tu? Gelatin is considered as al-istihalah. But if you look at fatwa Lajnah Daimah Saudi, for example, they don't consider gelatin al-istihalah. So istihalah is you change. But surfactant is still surfactant. There's no istihalah component there. You cannot even use al-istihlak. Istihlak is hyperdilution. Istihlak tu macam contohnya water that is more than 2 kullah, more than kullatain. So if you put najis in there, it is considered as pure because it's more than kullatain, more than 2 kullah. Kan? Orang Melayu panggil 2 kullah. Kan? So more than kullatain is considered as clean. So the concept is al-istihlak. So here is istihalah is not applicable, istihlak is not applicable as well. So halal ke haram?
Haram. Tapi
Why?
ambil konsep darurat.
Okay. So the issue is first, even if you use porrectan alpha, is porcine. If you use berectan, it is still it's cow. Yes, it's cow, but it's not cow that is slaughtered. Kan? You takkan ambil surfactant tu hidup-hidup. Kan? Bukan macam susu. Susu lembu tu hidup-hidup tak apa. Kan? This is you ambil daging dia, you ambil dia punya lung dia, you ambil dia punya ni. So the cow is not slaughtered under with ni kan. It's still, even if it's cow, it is still the original ruling, it is still not permissible. So original ruling is not permissible. If you ambil surfactant, you saya saja bagi kat siapa kan, it is still considered as haram. It is not permissible. Kan? Dia bukan al-aslu fil asya al-ibahah. Hukum original ruling for everything. Al-aslu fil manafi' al-ibahah. Original ruling for everything that gives benefit is al-ibahah, is permissible. But this one, there's already, it is the original ruling is already haram. Very clear, because it is porcine, because it is not slaughtered and so on and so forth. The original ruling is clear, it is not permissible. But that is why surfactant you don't give to all babies. You give for babies with clinical indication. When there is clinical indication, there is the concept of al-darurah. Al-darurah tubihul mahzurah. Darurah makes everything that is impure, that is not permissible, becomes permissible. Ad-darurah tubihul mahzurah. Darurah membersihkan apa-apa benda yang haram. Tapi you need to remember, ad-darurah tu tuqaddar bi qadariha. Ad-darurah tuqaddar bi qadariha. Darurah has its own limitation. You cannot just bagi siapa-siapa baby semua nak bagi. You cannot just bagi berapa banyak yang you nak bagi. No, you need to use clinical indication. So Islam is very clinical. Islam is very evidence-based. So you need to follow the limitation. You cannot just give as much as you want. You need to give as per clinical indication. So when there is darurah, it is permissible. So that is
Doctor,
why
I would like to ask, if it's not a clinical indication, is it still benefit the baby?
no,
Okay.
because surfactant in sulfation, you give surfactant already have is also associated with some problem. Surfactant it may associated with pulmonary hemorrhage, for example, and it is costly. One vial costs, I think, few thousand. One vial costs few thousand. It is expensive. It is expensive. So you don't give it like whatever you want. So you need to give it with indication. Okay, so and then the other problem with respiratory for premature babies are apnea of prematurity. As I mentioned before, they may just forget to breathe. Kan? Kita ingat breathing ni is something that is simple, tak payah fikir, tak payah berusaha. Tu kita breathing macam biasa. Sedangkan actually the capability to breathe is actually a ni'mah from Allah. It's actually a ni'mah from God. Kan? Premature babies to breathe is something that is a struggle to them. So they may have apnea of prematurity. They need caffeine. They need aminophylline for them to actually breathe properly. And the people with asthma like me, easily Allah can take away our ni'mah of breathing. So we take breathing as for granted. But breathing is actually a ni'mah from God. IVH. So IVH is a bleeding in the brain, intraventricular hemorrhage. Why? Because they have immature vasculature. The vessels are more friable. It can bleed easily from the friable vasculature. They may have disturbed cerebral autoregulation of blood flow. So the control of blood pressure in the cerebrum is not well regulated. So they may have bleeding, so on and so forth. And they have liver immaturity, they have clotting factor deficiency, they may have coagulopathy. So all these are associated with intraventricular hemorrhage, so bleeding in the brain. And not just that, IVH is also associated with post-hemorrhagic hydrocephalus, because you know there's bleeding. This bleeding will clot, and this blood clot may block the passage of the CSF and causing post-hemorrhagic hydrocephalus. This is a known problem as well. They may have immature liver. The liver is not properly formed yet. So immature liver results in prolonged physiological jaundice because of liver immaturity, may result to kernicterus, bilirubin encephalopathy, and so on and so forth. They are at risk of infection, as I mentioned before. Because why? So maternal antibody can cross placenta. Maternal antibody can cross placenta. Mainly is IgG. Can IgM cross placenta? Yes, it can, but minimal. Not all IgM can cross placenta. Dengue IgM is among the IgM that is known to cross placenta. Most maternal IgM do not cross placenta. Mainly is IgG. So maternal IgG do cross placenta, but they usually cross the placenta around 22 weeks. So on. So before 22 weeks, there's no IgG that crosses the placenta. So if the baby is born at term, so the baby already has many weeks of maternal IgG transfer across the placenta. But if the baby is born at 25 weeks, for example, there's only 3 weeks of maternal IgG crossing the placenta. So the baby may have inadequate maternal IgG. And you know, by breastfeeding as well. So breast milk has IgA. Breast milk has IgA. So if the baby is being admitted in NICU, NEC, so they are not being fed. They don't have maternal expressed breast milk, for example. So they don't have adequate IgG. And you know, breast milk also has high content of probiotic and prebiotic. So probiotic is the condition of the milk that that promotes healthy bacterial growth. That's probiotic. Prebiotic is the good microorganism tu, macam bifidobacteria, lactobacillus. So these good bacteria are actually helpful for your immune system. It helps, it reduces risk of eczema, it reduces the risk of infection, and so on and so forth. It helps your immune system to mature. Okay. So these babies, they are not exposed to direct breastfeeding, for example. So when they are not exposed to direct breastfeeding, they are not exposed to express breast milk, they are more at risk for infection because of the immune system. And then delicate surfaces of the skin. Their skin are more fragile, are more delicate, and their mucous membrane also are more delicate. So these are all risks of breakage and risk of infection. And when they are admitted to NICU, we put IV cannulas, endotracheal tube, nasogastric tubes, central lines, all these. We need multiple blood taking, multiple venipunctures. So all these are risks of infection, because your skin is one of the first defense mechanism. The moment you break the skin, you are at risk of infection. Next is NEC, necrotizing enterocolysis. So there is increased susceptibility to NEC due to immaturity of the gut endothelial surfaces and enzyme deficiencies in the gut as well. So this risk increases with lack of breastfeeding. You put umbilical catheterization, because especially umbilical artery catheterization, you may impair the blood supply through the mesenteric artery. So when you impair the blood supply, your bowel through the mesenteric artery has less blood perfusion. When we have less blood perfusion, they may have hypoxemia and leads to ischemia and leads to NEC. So premature babies, they are more at risk of the Malaysian data suggests almost 30% of premature baby may have NEC. 30% of premature babies have NEC, and 4% of premature babies have NEC, and up from those with NEC, 30% need surgery, and 30% has mortality. So the mortality rate is 30%. So it's very high mortality rate. I've had a baby who had NEC totalus. So the whole bowel, the whole small bowel, the whole large bowel is NEC and gangrenous, that needs to be removed. And the baby died. Obviously, you cannot survive without any bowel at all. And then patent ductus arteriosus. So you know patent ductus arteriosus is, so in utero, so you learn this in your neonatal week nanti kan, transition into extrauterine life. So in utero, because the lung is full with fluid, so you have high pulmonary blood pressure. So what happens is your body, in utero, creates two shunts. The first one is through the foramen ovale, across the right atrium to the left atrium. There's a shunt there, from right atrium to the left atrium through the foramen ovale. So that's the first shunt. The second shunt is through the ductus arteriosus, from the pulmonary artery to the aorta, PA to AO. So this is the ductus arteriosus. So the moment the baby cries, what happens is you cut off the umbilicus. You cut off the umbilicus. The placenta is a very low resistance circulation. So the moment you cut off the placenta, systemic vascular resistance increases because reduces the low resistance circulation daripada placenta. The moment you cut, systemic vascular resistance increases. And then the moment baby cries, lung dia akan keluarkan semua fluid dia, so reduces the pulmonary pressure. So systemic pressure higher, low pulmonary pressure, kan? It will close the foramen ovale, kan? And then PaO2 will increase because masa baby dalam in utero, baby punya blood basically dia dapat daripada maternal venous. So PaO2 dia very low. The moment baby keluar, baby will get the oxygen, will the lung will be the main gas exchange, kan? So PaO2 will increase. Increasing PaO2 will cause the smooth muscle dekat ductus arteriosus to contract, kan? Also blockage of the prostaglandin as well. Blockage of the prostaglandin, blockage of the COX-2 pathway, kan? So apa akan jadi? Ductus arteriosus will close, smooth muscle will constrict and close the ductus arteriosus. This closure of ductus arteriosus requires a mature and strong smooth muscle. So in premature babies, the smooth muscle of the ductus arteriosus are not yet mature. The blockage of the COX-2 pathway with oxygen and so on and so forth also not that strong, not that good. So that is why many of them have persistent patent ductus arteriosus. And this patent ductus arteriosus sometimes may cause problems. They need ventilation, they need diuretics, they are in failure, and so on and so forth. Feeding problems. This may result from the uncoordinated sucking and swallowing. Also from gastroesophageal reflux disease. Dia punya cardiac sphincter tu is not strong enough. The cardiac sphincter is not strong enough, they may have gastroesophageal reflux. You know, your stomach has two sphincter, kan? Pyloric sphincter and cardiac sphincter, kan? So cardiac sphincter dia is not strong enough. So sometimes they may have gastroesophageal reflux disease. They may have swallowing problem. As I said before, they're proper sucking only by 34 weeks. Before 34 weeks, they cannot suck, they cannot swallow, kan? Even after that, we need to train them. So sometimes even after training, they boleh suck, dia boleh swallow, tapi dia tak boleh coordinate. They may have uncoordinated sucking swallowing mechanism. So that's the problem. Dia boleh suck, dia boleh swallow, tapi dia tak boleh nak coordinate dengan dia punya breathing. So they may have feeding problems. They may have anemia of prematurity. Why they have anemia of prematurity? Because they don't have enough iron storage. They don't have enough iron storage. They may have vitamin E deficiency because they are not exposed to sunlight and so on and so forth. They may have because nutrition as well. They don't have enough vitamin E from nutrition. They may have exaggerated physiological anemia because why physiological anemia? Because fetal blood is from apa? What type of blood? What type of hemoglobin? HbF, kan? HbF. So HbF has shorter half-life. Bila ada shorter half-life, they may develop anemia of prematurity because and they may have jaundice and so on and so forth. And bila dia masuk dekat NICU, apa kita buat? Kita ambil darah. Ingat ambil darah sikit ke? Contohnya, if you have a 1 kilo baby, kan? Berapa banyak blood baby tu ada? Total blood volume, body blood volume, total blood volume is 80 mils per kilo. 80 mils per kilo, that is total blood volume. Kan? The whole body baby tu ada 80 ml of blood total. Okay, can you imagine? If you take full blood count, for example, you need around 0.5 mils. If you take blood gas needs 0.3 to 0.5 ml blood. If you take renal profile, liver profile, you need around 1 ml. If you take coagulation, you need around 1.8 ml. If you need to take things like plasma amino acid, you need around 1 to 2 ml of blood. Do you take once full blood count? You take several times. Sometimes you take gas every 4-6 hours. Some babies, kalau on HFO, you take blood gas every hour, every 2 hours. 0.5 ml, 0.5 ml. Kan? You ambil PT, APT, INR already 1.8 ml. Almost 2 ml. Is it a lot? Kan? Kalau you nak kena ambil first baseline, kalau you nak ambil cross match, for example, you need around 0.5 ml juga blood. And so it's a huge number for a very small baby. So kalau you ambil blood culture, for example, you need 3 ml for blood culture. Kan? You need around 3 ml for blood culture. 3 ml over 80 ml total. Is that a lot? That is a lot. Kan? Sometimes you take 5 ml, then you take frequent. Kan? Of course, they can be iatrogenic as well. Retinopathy of prematurity, as mentioned before, because of abnormal vasculature and also because of oxygen therapy. So, but the main factor for ROP is premature. Being premature baby is the main risk for retinopathy of prematurity. Rickets of prematurity, as mentioned before, because lack of substrate calcium and phosphate, and also vitamin D deficiency resulting in rickets of prematurity. A long-term problem, they may have bronchopulmonary dysplasia, chronic lung disease, they may have poor growth punya issue, they may have CNS dysfunction resulting into cerebral palsy and so on and so forth. So prematurity is among the major risk factor for cerebral palsy. Bronchopulmonary, this is an example of an X-ray of a child with bronchopulmonary dysplasia. This is very, very bad because of prolonged ventilation, oxygen toxicity. Oxygen is a free radical. So all this can result in bronchopulmonary dysplasia. So if you give too much oxygen, oxygen is a drug. If you give too much oxygen, you may cause the baby to have bronchopulmonary dysplasia, may need oxygen for lifelong, for a very long time, long-term oxygen therapy. If you give too much oxygen, the child may go blind with retinopathy of prematurity. Also, growth is restricted due to feeding punya issue. You need to because the child may need ventilation, needing higher calorie and so on and so forth. So vitamin and iron deficiency, micronutrient deficiency, CNS dysfunction, as mentioned before, things like cerebral palsy, intraventricular hemorrhage, periventricular leukomalacia, all these are associated with neurological sequelae, post-hemorrhagic hydrocephalus, as I mentioned before. Why? Because the blood clot, it blocks the CSF pathway. And then learning issues, prematurity is associated with autistic spectrum disorder, associated with dyslexia and so on and so forth. with deafness, especially when they are on antibiotic for a very long time, and so on and so forth. Mental subnormality as well because of sugar control and so on and so forth. Okay, so in a nutshell, babies, premature babies, they are associated with lots of problems from head to toe, IVH, CNS problem, cerebral palsy, post-hemorrhagic hydrocephalus, retinopathy of prematurity, feeding issues, sucking, gastroesophageal reflux, respiratory distress syndrome, hyaline membrane disease, chronic lung disease, patent ductus arteriosus, cardiac failure, NEC, feeding issues, and so on and so forth. So from head to toe. Right. That's it. Any question? Penat belaka, tidur belaka dah semua. Any question?
Doctor, I want to ask about the retinopathy. Just now it is under short-term complication. So the retinopathy is reversible?
So they may undergo several procedures. They may undergo several procedures. They may undergo laser punya surgery. So some of them it can be reversed. Some of them they go into permanent blindness and so on and so forth. Depending on the severity, depending on how soon we can correct. Depending on, because the child need to be stable enough to go for surgery and so on and so forth.
All right, thank you, Doctor.
Okay. Any other question?
Doctor, regarding HIE, why don't we classify PRETERM according to the Syed classification? And is there any classification to classify HIE or PRETERM? Thank you.
Again, classify what?
HIE, hypoxemia ischemia in PRETERM, because Syed is 4 term and also 35 above. So
So yes, there's no specific criteria for actually, but we still use almost the same criteria lah for even for premature babies, because there's no specific criteria for premature babies. That's the problem, because to do this study in premature babies is very difficult, because assessment of the tone is different for premature babies. There's not enough data whether even cooling therapy is useful in especially extreme premature babies. So and it's very difficult to do study in extreme premature babies. So that is why for now we are still using the same criteria, but with caution.
thank you, Doctor.
Yep. Okay, I think it's already 10:50 and you have another class at around 11. So I think that's all. I think if you have any other further question, we can discuss later, inshallah. Okay. Assalamualaikum warahmatullahi wabarakatuh. Let's end our session with tasbih kafarah.